You're listening to
CRST,
the podcast
from Bryn Mawr
Communications.
I'm your host tonight, Ken Beckman. I'm a cornea specialist in Columbus, Ohio. I happen to have a very large dry eye practice, and so I'm really glad that we're going to have an opportunity tonight to talk about dry eyes and how it affects our clinical practice. Tonight's guest is Dr. Priya Mathews, who's also a cornea specialist in Sarasota, Florida. Priya, welcome. Thanks for joining us.
Thanks so much for having me. I'm really excited to talk about something that I deal with all day, every day.
Every day. That's right. Can you give us a brief overview of like your practice setting and how dry eye is involved and how it impacts your clinical practice?
Absolutely. So, as you mentioned, I'm in Sarasota, Florida. I'm at Center for Sight, and so I do a lot of cataract surgery. This is a perfect location for that, and as well as cornea transplants and LASIK as well. Because we are doing so much cataract surgery and also a lot of premium cataract surgery, really it was obvious, a no-brainer, that we had to get our act together about dry eye. And so over the past few years, I've just seen what a difference it makes to, if you want a premium outcome, you need a premium surface. And so, emphasizing that from the beginning rather than doing the surgery and then kind of backpedaling and trying to treat the dry eye afterwards. So that's really been an emphasis for me. And so when I came to Center for Sight, we do thousands of cataract surgeries at this practice. I realized, we really needed to improve the efficiency of the dry eye clinic. And I actually started a dry eye clinic there because there needed to be a place that patients could get optimized prior to surgery. And then for those who already had surgery and may have temporarily decompensated, they need a place to go. And so that's where I started our dry eye clinic last year.
Well, that's really great. And we're going to get to in a moment about a discussion about starting a dry clinic. I just wanted to ask you, since you brought up the surgical part, can you go into a little bit on how dry eye impacts surgery and impacts outcomes?
I tell every single patient that the numbers and having a healthy, smooth cornea is essential for cataract surgery. Let's take out just even the premium part of it. For basic cataract surgery, the better shape that the cornea is in, the better you're going to do afterwards and the healing afterwards. And we always hear patients come after surgery. They say, I didn't have dry eye before, and then I had cataract surgery, and that's what gave me the dry eye. And we all know, right, that that's not actually what caused the dry eye. It may have been the straw that broke the camel's back, but these patients have pre-existing dry eye. So it's really up to us as a cataract surgeon to optimize their cornea as much as possible for better healing. And then also biometry, of course, it's so important that in order for our numbers to be exactly accurate on any given day, and I repeat a lot of biometry, I would say probably half of my patients, I'm repeating their biometry. It seems to be especially worse in the summertime in Florida. I think there's air conditioning blowing into everyone's eyes. And I was just talking to my team about this today. So about half of patients I need to repeat it. When I look at the testing, the stigmatism is not matching, or there are other signs of dry eye on the testing, and then of course exam as well, which we'll get into, then I know I need to repeat those measurements because that could change the diopter lens by even 2-3 diopters. It makes a difference whether you put a toric or not. So it's completely changing what your surgical plan is based on the biometry.
Yeah, I really agree. In fact, I tell my patients when I make them go through this draconian treatment of their dry eyes and come back several times before we're ready to proceed, there's three things that I'm trying to do. I call it my dry pre-op triad of what I'm trying to do before they go through cataract surgery and why it's important. So number one, obviously, is to prevent infection. Number two is, as you said, improve the surface so you can get accurate measurements. And number three, even if you have accurate measurements and have the proper lens, you want to prevent the post-op aberrations that these patients may have because of their poor surface, especially in a premium lens. And what they have to understand is this is a lifetime of treatment. So just because you have the right lens and the dry eyes can flare back up, you have the problem in the summer in Ohio, we get it in the winter when it's cold and the heat's on and there's no humidity. and along with the summertime with the air conditioning. So it's really a year-round thing where I am. So I really agree with your approach. So that brings us back to the dry eye clinic, and I'm glad you said you started one. I did that a number of years ago myself. And if you were advising somebody on how to start a dry eye clinic, what would you say would be like the essential tools needed, at least initially, to start, and then moving on to some of the more expensive or esoteric, things that not everyone needs but are just nice to have?
Yeah, I think the first thing to do is because it's hard to jump from nothing to a dry eye clinic is the first step would be educating the doctors that you work with. And this takes repeated times, not just one time. So we have 5 cataract surgeons and over 20 optometrists we work with. So we actually created a protocol. And over the past 5 years, many times we've given the same lecture and teaching to the optometrist. This is how you do a base. These are things to look for with a dry eye exam from the moment you walk into the room, right? Eyelids, cornea, we're going to go through all of that. And then from there, these are the managements that you can do according to one or multiple problems. Eyelids, surface, is there autoimmune disease? And so really educating and empowering, especially the optometrists, to do the first level of care. Like they should all start the prescription medications. We should all get the patient started. And then after that, so we really developed that protocol, which has been great. And it really made a huge difference because these patients were then optimized better and then sent to us for cataract surgery. But there's going to be some patients that need more than that and a place to have treatments. So I think what's essential is to have the right support. And so we have a PA that I knew that she was going to be essential to the success of the dry eye clinic. I needed someone that could be on ground zero all the time. That, of course, I would be there for all the consultations, for all the decision making, but someone could help support me to do, for example, serum tiers. So we do platelet-rich plasma, PRP, in-house, and that's been a game changer. We have like over 120 patients every month that get it, a 3-month supply. And so she draws the blood and prepares it and gives it to the patient within our practice. She also does, the IPL treatments, ILUX. So it's very important to have the right people. And some practices there may be some optometrists, or maybe there may be another MD that you work with. There has to be a champion. So I first did everything myself, and then when it got too much, that's when we started doing it together. And I think that's really important because you have to have the capacity for these patients because it just continues to grow. And if you're doing surgery, then you're going to need help from someone else that can help do these procedures. And so that's essential. Then trying to figure out what the best in class is important. So trying everything, being really familiar with all the products and treatments, and understanding what are you going to offer and for what kind of diseases. Like when do we use IPL versus when do we use LipiFlow or iLux? Um, versus when are we going to do meibomian gland probing? So that all of these are important to have different tools because, as you know, dry eye disease is so multifactorial. So whatever each patient needs is very different.
That's great. I mean, it seems like you have a pretty well-oiled machine, and you mentioned a lot of these sophisticated devices that you have, which I think ultimately, when you get a full speed dry clinic, that's what you're going to have. But a lot of physicians have asked me about getting started early on with a minimal investment. So some of the things that I typically mention would be really emphasizing the history. That means whether you're using a survey or just asking pointed questions and training your technical staff how to elucidate that. But then other things like tear breakup time and corneal staining, to me, are probably two of the most useful things without cost that I do all the time. And so I think that it's nice to know that if you can come up with a good system without investing a lot of capital between those types of things, you can get started and really manage your eyes before you even get into any of those other treatments.
I completely agree. Just a solid exam, looking at the eyelids, is it floppy or not? Looking at the meibomian gland disease. I think if I had to pick one thing, I agree with you. The punctate epithelial erosions, especially central, is the most important marker to me, especially if you have central staining, then I always repeat the biometry no matter what. And that's so easy to do. I use fluorescence every single patient that I'm gonna do surgery on, and really every patient I ever see. So, it's a very quick and easy, and you can really make good decisions based on a solid exam.
I agree. I would probably say that a fluorescein strip to me is my most valuable instrument. Because between breakup time and staining, I use that on just about every dry eye evaluation before I get to anything else. And those are really, really useful.
I
As
agree, and I
I
use Lissamine green too. I love that. Uh, I do, when I see a lot of Lissamine green staining, especially on the conjunctiva, I'm thinking also about autoimmune disease. And that's huge, and I think that we are getting both the incidence and the diagnostic capabilities of autoimmune disease is getting better, and so many times I will refer my patients to rheumatologists based on their dry eye exam only, and it turns out that they have a comorbid condition.
Oh, yes. It's really important to think of dry eye disease as a systemic disease and asking those pointed questions again and working with the primary care or the rheumatologist or allergist, whoever dermatologist you may be working with, they can really help you manage the systemic component of whatever's the underlying cause. And so then taking the next step as we expand our diagnostics before we get into the real pricey stuff, a couple of things that I commonly use, and I'm sure you probably do, are things like osmolarity and MMP9 testing. So those aren't quite as scary to bring in your clinic and maybe a good first step. Can you talk a little bit about how you use those?
Yeah, we've kind of gone back and forth about using it. I think it's very informative, and patients like seeing a quantitative measure that they like numbers, right? So when we just look and tell them, I mean, they'll believe us, but they like pictures. They like seeing how their meibomian glands look. They like hearing the number about the osmolarity. So that can be useful in kind of gauging trends over time and even reassuring the patient, okay, looks like your numbers are getting better. This is what this indicates. So that I find that it helps with trends.
I agree. For me, when I have a new dry patient, we tend to get an osmolarity at baseline. And I like
Mhm.
to get an MMP9, if not the first visit, in one of the early visits, and that's as a baseline. Now, the MMP9, I don't then repeat very often unless something's really triggering it. But the osmolarity, I tend to do about once a year on these. But in an ideal world, it would be great to see it every visit, but that's just not a practical thing to do. You can't, it's kind of like I feel like I want every test to be done every visit, but have it be the only test that I do because
Right.
everything is something else. So it's just not practical. But I think those are great. I guess the hard part then is for the growing dry eye clinic to then decide, okay, this is great. I'm seeing a lot of patients. I'm doing some, rudimentary testing, some a little more advanced testing. Where do I go next? How do I balance, you know, just doing what I can do and using my clinical acumen versus getting all of these devices? How do I pick which one? So how do you approach what you're going to bring in before you get to the treatment part, just the diagnostic part even?
I like separating it by eyelids and then ocular surface. And eyelids, first of all, the meibomian gland, the blepharitis, is there Demodex? Or I see a lot of floppy eyelids. What's the status of this? Sleep apnea? Do they have it? All that, the eyelids tell so much, and the position of it's so important. And surprising how many patients have sleep apnea actually and floppy eyelids. So that all I always tell patients from outside to in before we do intraocular surgery, we need to get your lids like take care of the floppy eyelids and make sure that they're protecting the cornea. So that should be optimized. And then also from the ocular surface, looking at whether it's aqueous deficient, like you mentioned, or evaporative, and then targeting what prescription I'm sending based on what I'm seeing. I really like, cyclosporin-based medications for uh, aqueous deficient, especially. For evaporative, we have some new options that are on the market now. And again, I'm the type of person where I really like using different things depending on how the exam is. What are your thoughts about that?
Oh yeah, well, the unfortunate part is in an ideal world, I'd like to be able to give what I think will work best.
Yeah.
Unfortunately, I can't. I feel like we could spend so many hours on the phone and online trying to get through a prior authorization that I'm almost at the point now where I'll pick what are the 3 or 4 options that are at least acceptable or reasonable, and my staff will write one, and they know just take the path of least resistance, at least initially. And I have so many patients that I might think, okay, you're starting on lifitegrast, and they come back in for their follow up, and I'll say to them, okay, we're going to start this. What did you get? And literally half the time or more, they're on something else.
I completely agree, and that's just the truth, right? The practical. We have to address and be aware of this if we want our patients to be compliant. Because at the end of the day, if it's so expensive, they're just not going to do it. So I've worked more with specialty pharmacies, which has been really nice for us in this area to help us with that burden of prior authorizations uh, and then I try to give a heads up to the patients. Okay, hopefully no more than X amount for certain. So and that seems to make a difference. And it also just taking an extra 30 seconds to explain to the patients why it's different from just using another artificial tear.
Oh, I absolutely agree. I think that without the specialty pharmacies, we would be in big trouble. And I tell the patients the same thing. I say when you find out when they tell you it's not covered, make them tell you what is your actual out of pocket cost, because sometimes they just try and scare them. And then I say, don't walk away. I want you to call my office, and we'll see which one we can get through. And I feel like more often than not, they're not on the one that I wrote initially. But honestly, as a first line, even if it's not my first choice, most of them are at least reasonably effective. And we see the same thing with over the counter allergy drops. You can't write a prescription for any. They're going to get one of them and it's never worth the fight. Or even a lot of the primary glaucoma meds, they're going to get shoved into a cheap generic prostaglandin almost every time. And if you wanted something else, I wait and see if the pressure's low enough and then I cross that bridge. And I think that's what most doctors have to be comfortable with when you talk about allocating resources and having a staff that's going to be helping you. The last thing you want to do is have them spend 4 hours a day doing these kind of phone calls.
Right.
So,
And I
so
think actually being able to treat dry eye, this is just part of the game, right? You have to be able to talk about access and prior authorizations and have a good system and educate your team too about it.
So then let's get back to the surgery part. You mentioned that you'll bring them in and do the evaluation, and you often end up repeating biometry. Let me ask you first, what are the standard surface tests that you do prior to a routine cataract evaluation? And then if you find a problem, what would be your go-to course of how you would treat them and when you would bring them back to eventually get them cleaned up?
Yeah, so when my techs are pretty trained that especially the ones that do the IOL master, they actually grade the patient like the clarity of 1 to 4 distortion when they're doing the IOL master and they write that in the notes section. Before I walk into the room, I'm looking at all the testing, including the IOL master, the Pentacam, and then there's OCT Mac and things like that. But really, I'm focusing on the Pentacam and the IOL master, looking at what the technician thought, how clear those images were when they were obtaining the scan. And then I'm looking at how the astigmatism matches, both the magnitude and the axis of it. And if they're completely different, I know before even going into the room, I'm going to repeat it. And then with the Pentacam, you can actually often see if it's kind of wavy on the borders, you know that this patient is dry before even going in. And then you hear that they have LASIK, and you kind of already know before you go in, is this someone that I'm definitely going to repeat? I'm on the fence. Then after going in and examining the patient, like the eyelids we talked about, the ocular surface, looking at the staining, I always stain every single patient. Looking at the tear breakup time, always looking at that. Then I make an assessment. Does this patient need, if it's very bad, no matter what, I'll always repeat it. But if they're also interested in anything, even a toric, and the stigmatism doesn't match us, I'm going to treat the dry eye and bring them back. If they want a multifocal, sometimes I'm on the on I'm on the fence about it. I start the dry eye treatment and then I bring them back. And I tell them, if you can improve and your surface looks good, I'm happy to do a multifocal. But if you can't, I'm not going to do it. Or if you don't feel like you can commit to like make this lifelong commitment of treating your ocular surface, then we should not do a multifocal. So I'm just very upfront about that from the beginning. And sometimes people are really disappointed actually. But I say, hey, I lead the dry eye clinic here. I don't want to see you on that side. Right? And I say that several times a day that I'd rather them be in glasses and happy than not being able to see clearly at any focal point. So that's really important. And the light adjustable lens, we do that as well, which I think is as a monofocal has a little bit more tolerance, but still, I think treating dry eye with a light adjustable lens is really, really important. And what I've noticed over the years is that those patients or often those patients may be post LASIK, post RK, and they're neurotrophic, so they actually don't feel very dry. So when it comes time for adjustments and they're very dry, they don't feel it. So now I've become much more aggressive pre-op with my light adjustable lenses, especially ones who have had previous laser vision correction to get them on a regimen because I say this is going to come back and haunt us later when we're doing the adjustments. Let's go ahead and start you on something now, even if you don't feel like you have a problem, which is very often people say to me. So then I usually bring them back depending on the severity of dry eye. Like today, I saw a bunch of patients ranging anywhere from 2 to 6 weeks. If it's really bad, I may even take 6 weeks. It's not as bad, maybe even 2 weeks. I'll usually start them on something chronic management, and then I may also do a pulse of steroids as well to kind of just help them get better faster and clear the surface.
That's a quite a course that the patient has to go through, and or the patient journey can be very daunting to them in the beginning. And I do a very similar thing as you do. I do like to personally, I'll typically hit them hard with a steroid right off the bat because I want to get the immediate effect. I'm talking about just for the pre-op, not necessarily for a routine dry eye. And I may not necessarily start them on the chronic med before the surgery if I can get them cleaned up with the steroid, only because I don't want them to be overwhelmed with the number of drops they're going to be using during that post-op course. And then usually as they're winding down their post-op course, then I might add the dry medication. And I like to keep the steroid on hand as a pulse for intermittent flare-ups. And so I usually use a milder steroid for that. But I agree, you have to be aggressive, and it's not uncommon to have several visits in several months. And if it's particularly cumbersome to get them through it and get them ready, I will take those other lenses off the board and tell them, look, we just got to get you as close as we can with a standard lens.
Right. I actually had a patient today who really wanted a multifocal lens. And I'm like, you're still not there. You're still not there. And then today she's like, you know what? I decided like I'm just gonna go with the standard surgery basic and I just don't want to make this commitment. And she was relieved and I'm relieved too, because I think she'll do fine with it. And I think that it was a really uphill battle if she wanted to get those lenses.
So before we wind up, then I wanted to talk about some other things that can be good adjuncts in the early dry clinic, or even in a more advanced one like yourself. There are some easier interventions such as punctal plugs or amniotic membrane placement, and then going further on into things like thermal pulsation or IPL, things like that. Can you talk about maybe some of those other things that you may do and maybe a decision making tree of how you decide which one you want to go to?
Yeah, I do punctal plugs all the time, every single day on many of my cataract patients, especially aqueous deficient ones. So I like the 6 month collagen plugs. So that's what I use. I usually always do two, but if someone I know likes it, then I can do all four. There's also Lacrofill now that we've been using. That's been good as well. And
Do you just use
so
that to get them through the post-op period, or you mean that's going to be their ongoing care?
for the punctal
For
plugs,
the 6 month plugs, are you just doing it around surgery, or are they going to continue to do that over time
yeah, I usually start with it. I do it because that's when I see them for surgery. But if they like it, then their optometrist can continue doing it.
rather than a permanent plug?
Yeah, I just, after talking to a lot of my plastics colleagues, it seems like sometimes these silicone ones, unless they're sized really perfectly, they can just get lodged in there. And so that's why I've kind of migrated to using more collagen personally. But I think there are some patients where silicone could be better. I think punctal plugs are great. It's easy, and then the reason why I also like the collagen ones are usually people don't have a huge effect in terms of saying they have a epiphora after that. They can tolerate it pretty well, especially when it's just the two lowers. Easy to do in your office. So people like that, and I do that often. And then a heating mask, I do that for almost everybody. I think it's great, and I think that people who find relief in it, then later on, if you bring up thermal pulsation or different options of warming up the glands to a higher temperature, kind of resonates with them because they understand this concept. And but that at least, and you would want them to do a heating mask afterwards anyways, so might as well get them started. I also like oral supplements. We do a lot of Hydro Eye at my practice. So patients like the thought of, just taking omegas and potentially helping the tear film as well. So that's been very successful at our practice, and easy to do. And you can direct patients online, or you can sell it in your office. We also started kind of offering some of the over-the-counter products at our practice. It could be a revenue generator, but the most important reason why we do it is because it's just easier for patients. And so you know what they're getting, and we say we have a bunch of products, and the underlined ones we actually have it here if you want to get it. So a lot of them choose to get it from us. That way they just know they're getting the right thing, and everything's right there. So those are easy things that you can do.
Well, that's great. I think that it's fun to be able to talk to somebody who has such a sophisticated clinic already, and it sounds like it's quite busy, and you have all the toys and all the tools and everything you need. And then on the other end of the spectrum, I get a lot of questions from people who are just starting up again, as we talked about, and how do you start from scratch without investing a lot of money? So I think there's a broad spectrum of what you can do. This was really, really helpful. Really nice to get your perspective and hear the things that you do. And I'm excited to try some things that I may have not done, and share other thoughts with you as time goes on. So, do you have any other last insights you want to share with us?
Yeah, this was really great to talk to you. And I think, just like you said, it seems like now at this point we've gotten to here, but it was a 5-year journey. So it started with my exam, and then recommending different treatments based on that. So everyone can do this. It's just an evolution that one by one, what fit into the practice over time. But it took 5 years to get here, from 2019. And so don't be discouraged. You can start anywhere. That's a good thing about dry eye. The exam is, essentially you could do it for very, very little. And it's easy that everyone can do it. And I would encourage all cataract surgeons to really incorporate this into their practice, because if you haven't seen post-ops that are dry, like they're coming, at some point, and the better that we can manage it beforehand, I think the happier the patients will be, the less refractive error, the less LASIK enhancements. It's just everyone's happy all around.
Well, I agree. And thank you so much for your time. And to the listeners, if you want to read more about this, starting and managing a dry practice or a dry clinic, take a look at the April issue of CRST. That's where we have our articles discussing how we approach dry patients and how we manage a dry clinic. Thank you very much again for your time and listening. Dr. Mathews, thank you so much for sharing your insights.
Thank you for having me.
For more shows like the one you just listened to, check out the podcast channel on itube.net.